Hi, my name is Donna Edwards, and today we'll be discussing the use of medication-assisted treatment in criminal justice settings. For people with OUD involved with the criminal justice system, a lack of access to medication-based treatment leads to a greater risk of returning to the use and overdose after they are released from incarceration. Availability of medication-assisted treatments within the criminal justice system. In jails and prisons, 30 out of 5,100 prisons and jails in the U.S. offered methadone or buprenorphine in 2017. 14 states offered methadone or buprenorphine maintenance for jail or prison inmates in 2018. In drug courts, 80% in a 2018 study, participants with OUDs were 80% less likely to graduate from drug court. 50%, approximately 50% of drug courts required participants to discontinue methadone or buprenorphine within 30 days in a 2017 study. %50 of drug court participants with OUDs received the MAT in 2018 study. 45% of state and federal prisons in the U.S. referred inmates for methadone maintenance after release in 2019. 29% of state and federal prisons in the U.S. provided referrals for community buprenorphine providers in 2009. Without MAT, there was 10 to 40 more higher risk of death from overdose within 2 weeks of release from prison in a 2018 study. Greater than 5% of persons with OUDs referred to treatment in 2014 by probation, parole, or drug court authorities received methadone or buprenorphine compared to 41% referred to non-criminal justice sources. Why is it so difficult to incorporate medication-assisted treatment into the criminal justice system? Misunderstanding or lack of information. Some of the reluctance of the criminal justice leadership to adopt MAT comes from a misunderstanding of MAT and the mechanisms by which the medications work. Some officials and practitioners view these medications as replacing one addictive drug from another. Others believe that forced withdrawal from opiates is a part of the living a clean lifestyle. Current policies do not support MAT. Some jails and prisons have policies that prohibit the use of controlled substances, including the medications used in MAT. Some drug courts might require detoxification from methadone or buprenorphine treatment as a condition of participation. No trained providers. Some jails and prisons do not have the capacity to treat substance use disorders in their facilities. Individuals already on MAT may be forced to disrupt treatment upon incarceration, leading to physiological and psychological problems. Some jails and prisons will arrange for a community-based provider to provide MAT. However, many facilities do not have trained medical professionals available. Medically supported withdrawal services available, but no maintenance therapy. Some criminal justice facilities will offer shortened MAT to detoxify individuals from opiates. However, when only medical supported withdrawal is provided to incarcerated individuals, rates of post-release overdose and deaths are high. Jails and prisons may only provide methadone maintenance therapy if they are registered with the U.S. Drug Enforcement Agency as an OTP. SAMHSA and state opiate treatment authorities may also certify jails and prisons as OTPs. Many correctional facilities do not have the personnel, capacity, or desire to register as an OTP. Jails and prisons may also make methadone accessible to inmates without having to become certified as OTPs through agreements with community-based OTPs. This would allow methadone to be securely transported to a facility from an OTP or enable inmates to be transported to a community-based OTP for dosing. For more information about these options, they can be found on the federal guidelines for OTP, opiate treatment programs. Concerns about security and liability concerns about security and the risk of diversion cause some jails and drug courts to either limit or deny access to buprenorphine or methadone. Diversion, misuse, and potential overdose are also liability concerns for some courts. These concerns can be addressed safely and effectively in most programs. Ensure linkages to treatment according to a 2009 publication. Only 45% of the criminal justice facilities provide any community linkages to methadone treatment clinics. Treatment within MAT and brief drug counseling integrated into the probation and parole system has shown positive results in terms of opiate use and rearrest rates. Support policy office-led diversion programs. Some police departments have engaged in training their officers to identify and divert nonviolent opiate-dependent individuals into MAT programs. One such program is the Law Enforcement Assisted Diversion-led program in Seattle, Washington. Change organizational policies to reflect a science based on the overwhelming evidence base for MAT. Many jails, prisons, parole, probation, and diversion departments are changing policies that prohibit the use of MAT medications. A growing number of states have enacted legislation authorizing or requiring expansion of MAT in the criminal justice system. Register as a MAT provider. Some jails and prisons have registered to become an opiate treatments program or have medical staff obtain buprenorphine waivers. For example, the Key Extended Entry Program, KEEP, is a methadone treatment program initiated in 1987 for incarcerated individuals. KEEP participants receive MAT behind bars, and when returning to the community, they are discharged to outpatient KEEP programs. Research tells us effectiveness of medication-assisted treatment in criminal justice settings. There is an overwhelming evidence that medication-assisted treatment, MAT, is an effective intervention for addressing opiate use disorders, OUDs, in the criminal justice and non-criminal justice populations. Several meta-analyses and systemic review have focused specifically on its effects on probation, parole, jail, and prison settings. Some segment of presentation focuses primarily on the evidence base for the use of MAT within jail and prison populations and in community reentry after release. Withdrawal and cravings. Pharmacological benefits derived from the medications are well studied and well understood. Methadone and buprenorphine alleviate withdrawal symptoms and craving for opiates by stimulating the mu opiate nerve receptor in the brain. Because they bind preferably to the receptors, they can diminish the effects of illicit opiates that may be used, such as heroin. A person who is physiologically tolerant to opiates will not experience intoxication, euphoria, or sedation when receiving these medications in the proper dosage, and most people can safely and effectively perform daily tasks, including childcare, many types of employment, and other non-hazardous activities. Naltrexone, a contrast, binds preferentially to opiate receptors in the brain but does not stimulate those receptors. As such, it does not reduce withdrawal symptoms. In fact, introduction of naltrexone with precipitate the withdrawal for persons who have not already been withdrawn from opiates. Oral naltrexone have no provision effects for reducing opiate cravings. However, the extended-release formulation has been shown to reduce cravings in randomized trials and brain imaging studies conducted outside the criminal justice system. Treatment, entry, and retention. Methadone and buprenorphine are reliably proven to increase entry into the retention in treatment during incarceration and after release to the community. In contrast, meta-analyses have reported mixed or non-significant effects of oral and extended release naltrexone on treatment entry and retention in the criminal justice populations. Observational reports in a few studies with methodological weakness suggest extended release formulation may potentially enhance treatment engagement among probationers or parolees in the community-based settings. However, these findings must be replicated in better controlled studies. Illicit opiate use. Methadone, buprenorphine, and extended-release naltrexone have been reliably demonstrated to reduce illicit opiate in the studies involving jail, prison, probation, and parole populations. Much of the support for buprenorphine comes from head-to-head comparison with methadone, in which drug use outcomes were determined to be equivalent. Although oral naltrexone was found in one randomized experiment to significantly reduce opiate-positive drug tests among federal probationers, most studies have failed to find significant effects on drug use, largely as a result of poor medication compliance and high treatment dropout rates. Criminal recidivism. Studies employing suitable comparison groups have not found reliable effects from methadone or buprenorphine on criminal justice outcomes, including rearrest rates, reconviction rates, reincarceration rates, or self-reported criminal activity. Nevertheless, retention in methadone or buprenorphine treatment is often correlated with significantly lower rates of criminal activity. This finding suggests that methadone or buprenorphine may elicit indirect effects on crime by enhancing treatment engagement and reducing illicit opiate use. Further studies are needed to determine whether increasing retention and adherence in methadone or buprenorphine treatment leads to more consistent improvements in criminal justice outcomes. The effects of naltrexone on criminal recidivism have been more promising but mixed. 4 meta-analyses reported significant reductions in rearrest or reincarceration rates for naltrexone without differentiating between delivery in the form of pills, extended-release injections, or implants. However, a 2019 meta-analysis concluded that too few studies employing adequate methodologies have been conducted to reach firm conclusions about the effects on crime. A recent multi-site randomized controlled trial found no effect of injectable naltrexone or rearrest rates. Average numbers of rearrest or average time to the first new arrest over an approximately 18-month follow-up period. Additional research is needed to determine whether naltrexone produces reliable effects on crime and whether enhancing adherence to naltrexone regime leads to a greater reduction in criminal recidivism. Overdose risk. Studies employing equivalent comparison groups have not found reliable effects from administering methadone or buprenorphine during incarceration on post-release overdose rates. However, strong correctional evidence indicates that providing methadone or buprenorphine both during custody and after release in the community is associated with substantially lower rates of opiate withdrawal or mortality. Significant reductions in mortality have only been observed when participants receive methadone or buprenorphine beginning in custody and continuing for at least 4 consecutive weeks after release to the community. Any protective effects that might be achieved from prison or jail-based treatment appear to degrade quickly if methadone or buprenorphine are not delivered continuously in the community. Further studies using better experimental designs are needed to confirm whether providing methadone or buprenorphine during and after release from custody reliably reduces opiate overdose and death rates. Comparatively, less research has been examined with the effects of naltrexone on opiate overdose and mortality rates. Two recent meta-analyses concluded there were too few studies to estimate an effect size in overdose rates. However, multi-site randomized controlled trial reported a significantly lower overdose rate for participants on community-based criminal justice supervision receiving injectable naltrexone. Additional studies are needed to replicate this finding and determine how best to administer naltrexone to reduce opiate overdose and mortality rates. Health risk behaviors. Relatively few studies have examined the effects of MAT on higher health risk behaviors commonly observed among persons with OUDs in the criminal justice system, such as syringe sharing or unprotected sex with multiple sex partners. Correctional evidence suggests that provision of methadone during custody and after release to the community is associated with significantly lower rates of injection drug use and contraction of communicable diseases. Meta-analysis has also conducted that combining methadone with psychosocial counseling designed to reduce health risk behaviors significantly reduced syringe sharing, sexual behaviors, and contractions of communicable diseases among recently jail and prison inmates. Less research is examined the effects of buprenorphine and naltrexone on health risk behaviors. One randomized experiment conducted outside of the criminal justice system found significantly lower rates of self-reported HIV risk behaviors for a person receiving injectable naltrexone. More research is needed to confirm the effects of MAT on health risk behaviors associated with opiate use and determine what additional psychosocial interventions are needed to augment or maintain them. Medical practitioners must take a multitude of factors into account when deciding which medication to use in a given case. The likelihood of therapeutic success and dangerous side effects can be influenced by a host of variables. These include but are not limited to the following: a person's medication preference and motivation for change, age at onset, duration and severity of opiate use, other substances, if any, used in conjunction with opiates, co-occurring psychiatric or medical conditions, if any, prior history of and response to substance use disorder treatment, prior history of and response to MAT, family history of mental health and or substance use conditions, other prescriptions, medications being taken by the person. Overlooking these factors and selecting the wrong medication can have dire consequences, including an unwarranted risk of dangerous medication reactions, treatment dropout, and overdose death. Blanket prohibits against MAT or against certain medications such as methadone or buprenorphine are medically unjustified and potentially harmful. Requiring inmates to discontinue or change a medication regime that was previously successful is associated with poor outcomes and a lower likelihood of resuming MAT after release from custody. Worse, because of physiological tolerance to opiates declines during forced abstinence or while taking naltrexone, inmates required to withdraw involuntarily from methadone or buprenorphine face a substantially increased risk of overdose and death if they are discontinued treatment upon release and resume illicit opiate use. Best practices for medication-assisted treatment in the criminal justice system. No justification exists for denying access to MAT because physiological services are unavailable or individuals are unwilling to avail themselves to those services. Counseling and social services. The importance of physiological counseling in treating OUDs appear to be a matter of timing. In the early stages of treatment, when individuals are clinically unstable and experiencing withdrawal symptoms or drug cravings, medication alone may be adequate to enhance treatment retention and initiate abstinence from illicit opiates. Several studies in community-based OTP and physician practices found no incremental benefits from adding evidence-based counseling to MAT on treatment retention or illicit opiate use during the first 3 to 12 months of treatment. No justification exists, therefore, for denying access to MAT because the psychosocial services are unavailable or individuals are unwilling to avail themselves to those services. For many individuals, MAT alone may be enough to begin them on the road to recovery. For most people, however, MAT alone is unlikely to produce sustained recovery or healthy adaptive functioning over the long run. Approximately 35 to 75% of individuals, including those involved in the criminal justice system, discontinue methadone, buprenorphine, or naltrexone within the first year of treatment. Often within the first few months, counseling is needed, therefore, to maintain a person's initial motivation to change and assist them in identifying and resolving barriers to treatment adherence. As reviewed earlier, more research is needed to understand whether MAT produces demonstrated effects in criminal justice populations on important secondary or distal outcomes, including criminal and health risk behaviors. Combining MAT with psychosocial counseling produces larger and more sustained effects in these critically important psychosocial domains. Unfortunately, little is known about which types of psychosocial interventions produce better outcomes in combination with MAT, and when they should be introduced in the course of treatment. Medication dosage. Institutional policies limiting the dosage or duration of MAT are unwarranted and likely to undermine treatment effectiveness. Like any medication, methadone, buprenorphine, and naltrexone must be delivered in an adequate dosage and for long enough time to achieve the desired pharmacological effects. Some studies in jails and prisons have reported average methadone doses of approximately 30 to 50 milligrams per day over brief intervals of a few weeks to about 6 months. However, significant improvements have typically only been reported when doses exceed 60 milligrams and often higher than that, over several months, more than a year. Medication duration and tapering. Evidence is clear that long-term or indefinite treatment with medications for OUDs is often required for effective and sustained outcomes. In practice, successful taper from methadone or buprenorphine typically occur in only 15% of cases. The likely result of premature or unwarranted discontinuation of medication regimes. Administering MAT for 90 days or less, which is a common practice in many jails and prisons, offers no beneficial effects. According to the U.S. Surgeon General, successful tapering typically occurs, if at all, when individuals have been treated with MAT for at least 3 years. Certain clinical benchmarks for success should be reached before considering a medication taper. Evidence in general community treatment settings suggests that individuals should be abstinent from all illicit drugs and alcohol and stable with respect to their physical and mental health, vocational and educational needs, and family problems for at least 2 years before beginning to taper a methadone or buprenorphine regime. Because naltrexone is non-addictive and has relatively minimal side effects, fewer concerns are commonly expressed about tapering a naltrexone regime. Some experts recommend maintaining individuals on naltrexone for at least 1 year. However, some have been treated successfully on naltrexone for at least 5 years with no negative effects. Co-occurring mental health disorders. Approximately 15 to 20% of individuals on probation, parolees, in jail, and prison inmates suffer from a serious and persistent mental health disorder. Individuals with mental health disorders fail disappropriately on probation and parole, and co-occurring mental illness interferes significantly with the effectiveness of correctional substance use treatment programs. When mental illness is combined with substance misuse, the odds of criminal recidivism and failure in correctional rehabilitation appear to increase multiplicitly. Substance use and mental health disorders are reciprocally aggravating conditions, meaning that continued symptoms of one disorder are likely to precipitate relapse in the other. For example, a person recovering from drug addiction who continues to experience depressive symptoms has an elevated risk for relapsing to drugs. Conversely, a person recovering from depression who continues to use illicit drugs is likely to experience a resurgence of depressive symptoms. For this reason, co-occurring mental health and substance use disorders should be treated concurrently as opposed to consecutively. Whenever possible, both disorders should be treated in the same facility by an interdisciplinary team using an integrated treatment model that focuses on mutually aggravating effects of the two conditions. SAMHSA has published a therapist toolkit to assist delivering evidence-based integrated treatments for co-occurring substance use and mental health disorders. Participants should also have unhindered access to medical providers qualified to prescribe and monitor response to psychiatric medications and ensure these medications are used safely and effectively in combination with MAT for OUDs. A statewide study of community-based treatment reported that use of MAT was associated with significant reductions in inpatients' substance use treatment for individuals with co-occurring disorders, and the use of oral naltrexone was associated with significant reductions in inpatient mental health days, greater adherence to psychiatric medications, and lower rearrest rates. Post-release services. Success after release from custody requires the individual to continue receiving MAT, counseling, and other indicated services in the community. Institutional treatment alone without follow-up care is rarely successful. Worse, based on psychological tolerance declines if individuals are not maintained on methadone or buprenorphine while incarcerated, release to the community without follow-up care can lead to a higher rates of opiate overdose and mortality if they return to pre-incarcerated levels of opiate use. The factor that best distinguishes effective from ineffective prison and jail-based MAT programs is whether participants experience a smooth transition to follow-up care while on parole or after release to the community. Systemic reviews of research literature have concluded that significant reductions in criminal recidivism and improvements in employment are typically observed for post-release reentry programs that share at least the following characteristics. Community providers meet with participants prior to their release from custody to assess their treatment and social service needs, inform them about available community services, and develop a transitional treatment plan to ensure seamless receipt of indicated services after discharge. Community-based services are delivered immediately upon after release, are intensive in nature, at least 8 hours per week, and at least 6 months. Participants received at least a 4-week supply of prescriptions and preferably longer if needed medications. Counseling interventions are documented in treatment manuals. Are behavioral, cognitive, behavioral, and orientation, and are delivered by professionally trained service providers. Participants receive evidence-based housing, vocational and mental health services where indicated. Supervision officers maintain participant progress. Use of motivational enhancement techniques to increase compliance with treatment. Reward achievement of treatment goals and administer gradually escalating consequences short of reincarceration. For treatment, a train in other infractions that do not involve a new criminal offense. Preventing misuse. Criminal justice professionals have an important role to play in minimizing misuse of medications. These concerns are usually most pressing after participants have been released from custody and are taking the medications in the community. Several practical precautions have been demonstrated empirically to reduce untoward events toward the related to MAT. Observed administration. One of the most effective ways to prevent misuse or diversion of prescription medication is to require the medication to be ingested under the direct observation of treatment or criminal justice staff. After release from custody, ingestion may be observed by a medical staff person, probation officer, clinical case manager, or other approved individuals such as a trusted sober or pro-social family member or friend. Medication level monitoring. The presence of prescribed medications and their metabolites may be monitored through urine and other appropriate testing methods on a random basis to confirm the medication is being taken reliably. Medication event monitoring. A medication event monitoring system, MEMS, is a medication viral or cap with a microprocessor that records the date and time and number of pills removed each time the container is opened. Use of a MEMS provides a reliable indicator of appropriate medication use among individuals with severe mental health disorders. However, it has not been evaluated in a criminal justice population. Newer applicants designed for smartphones or other electronic devices offer more sophisticated methods for monitoring and enhancing medication adherence. Phone-based applications, for example, can deliver medication reminders and motivational prompts and use of facial recognition technology to confirm ingestion in real time. Studies confirm that use of such applications can enhance adherence in psychiatric and other medications. However, these methods need to be examined in criminal justice populations. Abuse deterrence formulations. Misuse and diversion of medications have been reduced significantly by combining buprenorphine with naltrexone, which elicits withdrawal if the medication is injected, administering the long-acting injectable formulation of naltrexone, administering methadone in liquid form, and administering buprenorphine in the form of a soluble sublingual film. Prescription drug monitoring programs. Prescription drug monitoring programs, PDMSs, are state-maintained database of specific medications prescribed within the state and other jurisdictions with reporting reciprocity. Reports typically include a list of prescriptions for controlled medications filled for a given individuals within the previous 12 months. As of April 2019, all U.S. states other than Missouri, as well as the District of Columbia, Guam, and Puerto Rico, had a PDM. Nearly all jurisdictions permit pharmacists, physicians, and other medical practitioners, example given nurse practitioners, to access PDMs information relating to their patients or clients. In addition, most states and territories authorize PDM reports to be communicated to law enforcement personnel, and approximately one-third authorize reports to community correction agencies or drug courts. PDM monitoring has been shown to reduce the incidence of dangerous medication interactions by bringing other medications taken by patients to the attention of the prescribing physicians and dispensing pharmacies. Statewide studies have found that requiring mandatory reporting to PMDs was associated with significant improvements in physician prescribing participants, including fewer individuals receiving overlapping prescriptions for the same opiate, obtaining opiates from 5 or more doctors or pharmacies, doctor shopping, or receiving refill authorization of 7 or more months. A recent study concluded that implementation of mandatory reporting to PDMs was associated with a 3 to 4% decrease in overall crime rates and a 5 to 7% decrease in violent crime rates. Examples of medication-assisted treatment programs in criminal justice settings. In this presentation, 6 programs are highlighted that have been used medication-assisted treatment, MAT, utilizing buprenorphine, methadone, and/or naltrexone to treat individuals with opiate use disorders, OUDs, in the correctional system, within jails, prisons, and reentry to the community. Each of these programs have achieved outcome consistent with research on the effectiveness of MAT in these settings. There are 2 basic models for provision of MAT in the correctional setting. The first, exemplified by New Jersey and Rhode Island, provides a full range of medication to treat OUD over a long-term maintenance period. This model aims to stabilize individuals over the course of their sentences and after release. The second model, exemplified by Kentucky and Massachusetts, focuses on relapse prevention. Often detoxified upon entry into the criminal justice system, individuals of OUDs are provided naltrexone immediately before release and for the period thereafter to avoid the highlighted risk of relapse on re-entry into the community. Both of these models appear to be more effective than programs that offer no MAT. Since the approaches have not been directly compared, there are currently no data documenting which model is more effective overall. However, based on the outcomes of related research, evidence indicates that offering all forms of MAT is likely to be more effective in most settings, and where possible, offering all forms of MAT is considered best practice. Both of these models appear to be more effective than programs that offer no MAT. Since the approaches have not been directly compared, there is currently no data documenting which model is more effective overall. However, based on the outcomes that related research, evidence indicates that offering all forms of MAT is likely to be more effective in most settings, and where possible, offering all forms of MAT is considered best practice. Choosing programs. While there is additional excellent programs that could have been featured in this section, the panel of experts considered these to be well delineated and replicable. Each has successfully delivered MAT in jail, prisons, or reentry, and has reported early evidence of promising results. Especially within recent years, varied program models have developed across the country. Programs including highlighted here are the continuity, changing and developing in response to many factors, including need, population development, and of the science of resource availability. These programs should not be taken as definite best practices in service delivery, nor represented by all potential program models. Rather, they represent models that have been effective in delivering MAT and reported promising outcomes in a variety of correctional settings. It is important to note that programs represented here were chosen in part because of the operate a variety settings, jail, prison, reentry, and combinations thereof. These settings present sustainability, different barriers to treatment, and consequently require substantially different service delivery practices. Therefore, the setting of the program should be taken into account in evaluating and applying the principles demonstrated by each model. Addressing challenges to implementing evidence-based practices and programs in criminal justice systems. As reviewed earlier in the sections of this presentation, dozens of studies, including randomized controlled trials, have been proven that medication-assisted treatment enhances treatment engagement during and after discharge from custody, decreases relapse rates, and is associated with reduced criminal recidivism, is associated with lower overdose rates and health risk behaviors. However, only about 1/3 and 1/2 of staff members in the state correctional institutions, community correction agency, drug courts, substance abuse treatment programs, and physician practices are aware of the health benefits of the medications used in MAT. The dominant approach to opiate use disorders, OUDs, in jails and prisons involves short-term detoxification and requires inmates to be tapered off proven medications within certain time limits. When buprenorphine or methadone are permitted for medical situations requiring immediate action, such as for the treatment of pregnant women, discontinuation of the regime is normally required once the qualifying condition has ended, such as after childbirth. Challenges to implementing medication-assisted treatments in criminal justice settings. Challenges overcoming the stigma and disapproval actions. Avoid stigmatizing languages such as substance abuse, addict, or relapse. Educate staff on the disease model of addiction and beliefs of MAT. Describe disorders that often co-occur with exacerbate substance use disorders. Explain common peer and environmental influences initiated of substance use. Describe low success rates and high overdose rates without MAT. Persons suffering from OUD face stigma and disapproval of MAT from criminal justice professionals and other in the social networks. A national survey found that most members of the public held negative views towards persons with substance use disorders were skeptical about the effectiveness of substance use disorder treatment. In a 2019 study, more than half, 58%, of drug court participants with OUDs experienced or observed negative judgmental reactions toward methadone and buprenorphine from family members and peers and self-help recovery groups. A recent report from Narcotics Anonymous World Services confirmed that some NA meetings unduly limit participants in individuals receiving MAT and may be less welcoming of such individuals. Negative judgments come in a variety of forms, such as minimizing an individual's recovery because he or she is receiving MAT, or wrongfully predicating that use of MAT will eventually lead to a person back on illicit opiate use. These reactions are not merely hurtful, but can interfere substantially with participants' confidence in their ability to meet their treatment goals. Several participants have shown promise for reducing negative attributes towards a person with OUDs and increasing endorsement of evidence-based treatment, including MAT. Using terms associated with greater empathy and optimism, such as recovery or reoccurrence use. Describing a person's previously unsuccessful efforts to quit using drugs without the benefit of proven medication and disheartened reaction to those failed efforts. Describing practical misuse prevention efforts that can be taken with prescription medications, such as observed medication ingestion. Referring participants to self-help recovery groups that are supportive of MAT or preparing them to deal with negative reactions that may experience in the groups. Educating professionals on the layperson about the disease model of addiction, including genetic influences, neurochemical changes in the brain, and the positive effects of MAT. Describing common environmental influences on initiation of substance use, such as trauma, peer pressure, and poor prescription practices. Describing medical and psychiatric disorders often co-occurring with exacerbate substance use, such as chronic pain, depression, anxiety, and PTSD. Challenge addressing threats to safety and security actions. Provide training to staff. Securely store medications. Verify medication ingestion. Conduct pill counts. Use abuse deterrence formulations. There are several safety and security concerns that accompany the implementation of MAT in jails and prisons. Diversion and misuse of MAT medication are chief among those concerns. Nearly two-thirds of jails and prisons report instances of non-prescribed use of buprenorphine, and approximately 20% report cheeking and other unauthorized concealment of prescribed buprenorphine. To address these concerns, correctional medical staff must be educated and trained on how to properly and securely store administer medications. MAT medication should be stored in secure areas with locked cabinets and refrigerators. The actual setting of medication administration may differ depending on the size of the facility. Individuals, custody levels, and housing locations, institutions must determine which procedures work best. The common procedures for medication administered in correctional settings include the scheduled pill calls line within the housing units, dispersal windows required by the DEA for dispersing methadone, administration of medication in a centralized location such as a medical clinic or infirmary, individual inmate release from their cells to a nearby nurse medication cart, cell-to-cell administration of medications from high-risk inmates, specialized units from persons receiving MAT or substance use treatment. Arrangements such as the pill call line or dispersal windows can call attention to individuals receiving MAT and contribute to the stigma or pressure from others to divert the medication for unauthorized purposes. Individuals administering or special units help to avoid these problems but require more staff time and resources. When administering medication, staff should closely supervise individuals to decrease the possibility of diversion or misuse. Dispensing medication in the form of a soluble film or liquid makes it considerably more difficult to avoid ingestion. Requiring persons to consume juice, crackers, or water after ingestion helps to avoid cheeking, and inspecting under the person's tongue and around the gums are methods for ensuring full ingestion. Dual mouth cheeks for both medical and correctional staff reduce inaberrant relapse or attention that can cause staff to miss non-ingest medications. Random pill counts and urine screenings to ensure medications being taken are also methods used to monitor diversions. All jail and prison staff, not just those dispensing medication, should receive in-service training on MAT, including an overview on the institution MAT policy and procedures, basic information about what MAT is and its benefits, potential side effects of the medications warranting clinical attention, and signs of medication diversion. For individuals who refuse or miss a dose, staff must fill out documentation accounting for the missed dose and return into the secure storage. If possible, staff should get the individual's signature confirming the medication was not taken. Staff must ensure medication are used before expiration. Both injectable buprenorphine and naltrexone require refrigeration, and once allowed to warm to room temperature, must be used within 7 days. For institutions interested or already using buprenorphine or naltrexone, there are abuse deterrent formulations of these medications. Suboxone and a combination of buprenorphine with naltrexone that is taken sublingually causes symptoms of withdrawal when injected. Vivitrol, a long-lasting formulation of naltrexone, or sublocade, an extended release injection of buprenorphine eliminates the need for daily dosing. Employing a combination of these methods and procedures can help address safely and securing concerns. Another challenge, advancing staff knowledge and skills actions, provide ongoing staff trainings, develop working groups comprised of correctional staff and community providers, institute ongoing peer supervision, establish peer monitoring, appoint change agents, training correctional staff on the proven benefit of MAT and addressing prevalent misconceptions about medications is a necessary first step in changing attitudes and practices. In-person and online training curricula have been demonstrated to enhance knowledge of attitude towards and willingness to adopt MAT among criminal justice and non-criminal justice professionals. However, online training alone is not enough to sustain the change because the effects have been found to degrade within 1 month and increase the knowledge do not necessarily translate into actual referrals to MAT. To encourage adoption and long-term staff support for MAT, training and other staff engagement initiatives must provide ongoing opportunities for staff to build skills, recall information, share knowledge, and deepen understanding. A randomized controlled trial conducted at 20 community correctional agencies found that combining training on MAT with an organizational link intervention significantly enhanced staff referrals to MAT. The 3-hour training taught correctional staff about the neurobiological basis of OUDs, the effects of agonist and antagonist medication in treating the illness, compatibility of MAT with behavioral counseling, and the available MAT resources in the local community. In addition, representatives from the correctional agencies and local MAT providers meet regularly for 12 months to discuss mutual concerns and resolve barriers to MAT services referrals and provisions. Although training alone was adequate to enhance knowledge of and attitude towards MAT, only the combined intervention significantly improved current and future MAT referrals intentions. A study conducted in 54 state correctional facilities found that training staff on the benefits of naloxone for reducing overdose mortality improved knowledge and attitudes about overdose reversal. However, knowledge acquisition did not necessarily translate into change in practice. Equipping staff with naloxone reversal kits, teaching them to assemble the applications, and providing videotape booster trainings improved staff members' confidence in their ability to intervene successfully in an overdose emergency and led to increased uptake of naloxone reversal kits by correctional officers and inmates. Additionally, other studies have reported increased adoption of evidence-based practice, including MAT in the community correction agencies and drug courts when programs offer peer supervision and monitoring to help staff maintain and update knowledge and skills, and appointed change agents, champions, within the program to advocate for continued marginal and administrative support for the services. The challenge with that was covering the cost of MAT actions, seek discounted MAT rates through the state block grants or appropriations, federally qualified health centers, FQHCs, and subsidized medication programs. State temporarily suspended the reclassified Medicaid coverage during the incarceration rather than terminate Medicaid eligibility. Employee benefits assisted to screen incarceration persons for coverage eligibility, help them enroll, and encourage engagement in covered services. Develop automated data exchanges to alert Medicaid and community providers about upcoming discharges of eligible or enrolled participants of shared relevant information. Have case management staff meet with the incarcerated person while in custody to coordinate post-release health care and social services, use of peer support specialists with relevant lived experience to support reentry and engagement in treatment post-release, address social determinants of health that can interfere with MAT outcomes via health homes and other supportive social services, allow community treatment providers to bill public or private insurers for in-reach service delivered in preparation for discharge from custody. Many state fund MAT for programs serving correctional populations out of state block grants or direct appropriations. In addition, more than 1,200 FQHCs located in inner cities and rural areas after buprenorphine at discounted fees for uninsured low-income individuals. Some jails, prisons, and community correction agencies have also been able to negotiate reduced price medications directly from pharmaceutical companies. The 340B Drug Discount Programs is a federal government program requiring drug manufacturers participating in Medicaid to provide outpatient medications to eligible healthcare organizations and covered entities at significantly reduced prices. Covered entities serve highly vulnerable populations, including hospitals treating the disproportionate share of poor uninsured patients, sole community hospitals, and rural referral centers, many of which treat justice-involved individuals. Covered entities may be required to provide discount medications to uninsured patients and those covered by Medicaid, Medicare, or private insurance. Far, the most common reimbursement for MAT comes from Medicaid, covering nearly 40% of all non-elderly persons with OUDs in 2017. With a few limited exceptions, persons in jails and prisons are not eligible for Medicaid or most type of insurance while incarcerated. However, legislative changes implemented in the Affordable Care Act have greatly expanded coverage for MAT and related services during community reentry. All state Medicaid programs cover at least one medication used to treat OUDs, and many states cover all three FDA-approved medications. As of February 2018, 36 states and territories covered methadone, covered buprenorphine, covered naltrexone, and more than half increased the coverage of naloxone to reverse opioid overdose. States also have discretion under Medicaid to cover rehabilitative services, broadly defined to include peer support specialists, supportive housing, and supported employment services such as job coaching. As of 2019, in April, 28 states sought to receive Medicaid waivers to provide substance use treatment to include MAT, counseling, and community support services. Homes have been established to address the complex service needs presented by persons with serious mental health disorders or two or more other chronic health conditions, including substance use disorders. Innovate models of healthcare delivery can help tailor treatment to the needs of formerly incarcerated individuals. For example, at least 11 states and Puerto Rico have established interdisciplinary care support teams, transitions clinic networks to coordinate post-release health care and social service for justice-involved persons. Barriers, nevertheless, persist in gaining meaningful access to Medicaid and other reimbursement coverage. Managed care entities may impose burdensome prior authorization conditions, require certain medications to be used as a frontline regime, or practice restrictions on the dose quantity or duration of MAT. Some states have been approved to impose work requirements on Medicaid coverage, cancel coverage for timely failure, and renew plans or report change affecting eligibility, change premiums of up to 5% of family income, place restrictions on non-emergency transportation for treatment, and impose fees for missed appointments. Navigating these complex coverage requirements can be prohibitively difficult for persons in the criminal justice system. Fortunately, several strategies have proven successful in creating better linkage to healthcare coverage for MAT and enhancing access to needed services. Suspending or reclassifying Medicaid coverage rather than terminating coverage, reducing unnecessary burdens on reinstatement. States have also discretion under Medicaid to cover benefits assisted to help identify and enroll eligible persons in Medicaid while they are incarcerated, and case management service to help beneficiaries identify, apply for, and enroll in treatment and social support programs after release to the community. States may cover peer support specialists with lived experience related to substance use disorders and justice system involvement to help individuals navigate the healthcare system and make it to the scheduled appointments. Finally, some states are experimenting with ways for the community treatment agencies to bill for in-reach therapeutic services delivered in preparation for discharge from custody. The Affordable Care Act also provides following funding for data exchange to improve information sharing and coordination of efforts between Medicaid, prisons and jails, and community treatment providers. Up to 90% of cost matching to help states build and promote the exchanges. 75% of cost matching for ongoing maintenance and operation of exchanges. Incentive payments for health provisions to use electronic records.